All right, good morning. Happy Saturday. Very excited to be here with all of you and this really exceptionally talented group of folks. I think really being at this conference is about sharing ideas, sharing challenges, and mutual respect. I would not be here doing what I do today I should have started with introducing myself. My name is Maria Quinn. I am the Director of Addiction Treatment and Recovery Support at Holyoke Medical Center. But I wouldn't be here with the colleagues that I have. And very early in my career, there was two people that really helped me out when I didn't think that I would continue to be able doing what I was doing at the hospital, starting up a consult service. The first was Ari Kriesman, who really would let me know it's not you, it's them. Doctors are mean, really. That's what he would say, because that was my experience. And the second was actually Haned, who I would say, I can't, this is so hard. And he would say, Maria, you are where you need to be. This is where your community needs you, and you need to find like-minded people. And this is really what this space is about. So continuing to, embrace each other and do the work that we do, because it is not easy. So today I really get to have the privilege of talking about addiction consult services across Massachusetts. And I have an awesome group with me, starting here with Alexandra Haggerty, who's a nurse practitioner at South Shore Medical in their addiction consult service. Next to her is Dr. Adam Chamberlain, who is the medical director at the Bay State Community Addiction Consult Service. And then next to him is Dr. Audra Williams, who's the medical director of addiction services at Lowell General. And then next to her is Dr. Mel Currie, and he's the chief of emergency medicine at Holyoke Medical Center. I thought it would be really great to have a different perspective in terms of not just all addiction medicine providers, but really hearing how another discipline has been impacted by having addiction consult services in the hospital. So I'm this old, really. I think a lot of you are too. So anyone who has started a consult service has likely felt this way, just in terms of walking into a space that has archaic protocols, just culture built around just old ideas and lack of resources. But establishing services for addiction services in any type of medical settings is often met with outdated opinions and ideas. Yesterday, people talked about setting up OTPs in neighborhoods and people not wanting them in the neighborhoods. We are essentially setting up shop where our roommates already don't like our friends and they haven't even met them, like seriously. And if you want some fun, ask your kids what they think this is. Mine thought it was an olden days projector. So there are between 60 to 70 acute care hospitals in Mass. And I say that because it depends on the source. So Mass DPH Division of Healthcare and Facility Licensing has it listed as 70 acute care hospitals. And then the Center for Health Information and Analytics has listed as 60. And then just to make things even clearer, I'm not actually sure how many addiction consult services there are in Massachusetts because there's nowhere where they're listed. So this is really my best guess at where they are with the X's on the different counties. The stars are where I am not sure if there are addiction consult services in the hospitals there. So Hampshire County, Bristol County, and Barnstable County. If I'm wrong, definitely let me know. And it's also important to note that all consult services across Mass look very differently. Some are staffed with MDs, some are staffed with NPs. And then I learned of one recently that is an addiction consult service that is actually just staffed with, I shouldn't say just is not a good word for anything that we do. It is staffed with a social worker and a recovery coach and no medical provider. Today, though, we're going to focus on these 4 hospitals. I was really, really fortunate to meet with each of these people for at least an hour. Mel, he gets to meet with me more often just because he's 2 floors down. But we really talked a lot about the work that we do. And we all have the same goals, really: improved outcomes, support, connections to resources, meds, education, harm reduction. But we all do it really, really differently. And that's important because it's based on our organization, our community, and I think really just our own personalities and how we do things. So at a glance, looking at Holyoke, I have 2 born dates of our addiction consult service: 2017, which is when I started working there doing the, I was doing the psych consult. Quickly saw that there was no addiction treatment happening and started doing it almost on the side, like just telling hospitalists like, oh, I feel comfortable doing this even. And really my skills from that came from being an OBAT nurse, a nurse for over 10 years. And that's really where most of what I learned in terms of when I started treating, because the 1-hour course I had in NP school, 1-hour course, not a long semester, in addiction medicine is really didn't cut it in terms of the skill set. So started doing that and then actually got money in 2020 and a name and staff, and it became awesome. So our consult service is staffed with myself and an RN, a recovery coach. The makeup of Holyoke is about 51% Hispanic. Then looking at Lowell, they have 2 campuses. What stands out to me in really looking at Lowell, and when I was talking to Audra, is when it started in 2020, they were staffed with an NP, and then today they've quickly grown, and this also includes their staff from their Bridge Clinic, to 1 FTE MD, 2 FTE NPs, 3 recovery coaches, and a social worker. Really super jealous of the staffing. But also look at the diversity just in terms of the community there. It's 17% of folks there are born outside of the US. Even when talking to them, it was hard to decide what we were going to talk about because so many things could just go on forever and ever. And this is one of those that was really, really interesting to me. Then looking over at Bay State Franklin, which is where Adam is at, and it's 3 small community hospitals, nowhere near each other. They all have, small number of inpatient beds. Bay State Franklin has 89, Noble 65, and Wing 46. The staffing there is also different in that he was telling me they have a care coordinator that works for all 3 sites remotely, which I thought was really, really innovative and unique. And then South Shore Hospital is a big hospital, similar staffing with MD, recovery coaches, but they also have the biggest ED that I've ever heard of. I actually thought it was a typo when the information was sent to me, 117 bed ED, that's just massive. So different themes came up as we were meeting, and I narrowed it down to a few. And when I was talking to Adam, he was really talking about just challenges that he was having with care coordination and getting people to continue on medications that he had started there. And I said, oh, well, let me look at that. So I went to the BSAS, which Dee went through yesterday, the BSAS dashboard that really does have a lot of rich information. And I looked first to see, well, what's the access like to OTPs from Westfield, which is in the blue. I think this is the laser and it doesn't work, but in the blue. And the little orange circle indicates where the OTPs are, and then the green around it is like 15-minute driving time. So there's a whole bunch in it's like the green eggs and ham map for me. But you can see that there's a lot of access to it. But then when I look to see about OBAT providers and buprenorphine, there's none. So can you tell me a little bit about how you addressed that and what you did to make sure patients had access to care?
Working. Okay.
You got
Talk to the ice cream cone.
Yes.
Okay. Everyone can hear me now. Thank you so much. And I'm going to just start by saying thank you to you as well, Maria, for paying it forward. You were thanking your mentors, and you have definitely helped me as well in a similar way as I started, because we just started seeing patients last November. So it's a relatively new service, but really thank you so much for your support. And I will start by saying it definitely, it's a challenge for sure to have these three sites spread out so far apart. And I think a lot of the struggle we have with access to treatment really is because we're so rural. And I think this is one of the, what is it, the structural determinants, to look at Dr. Hernandez, it very much in terms of access to care, but in any other kind of resource as well. On the first day, there was kind of there was a lot of red areas, but then there was these 2 empty areas, and a lot of the patients we serve, I don't know if you can see it right on the map, are kind of right in that little valley where you don't see any. They call that the hill towns of Massachusetts, and it's a lot of places, you know, that are very poorly served. And so when I started, it was actually kind of an interesting transition, because I work at Bay State Franklin Medical Center. So when I started there, I was used to actually having quite a bunch of resources, right? So you see patients at the hospital. We started the Victory Consult service there. Oh, we have 2 OTPs to choose from afterwards, right in town. We have OBAT providers. We have kind of all of these different community organizations that are so important that we keep hearing about. And it was like I got kind of lulled into this sense of, oh, this is so great. We've got all the services right here. And then, I should say though, actually, you know, that didn't happen just kind of by accident. Like a lot of people over the last 10 years, 20 years, really put a huge amount of advocacy and made that happen. A lot of those people are in those rooms. So I want to thank them for doing all of that work and allowing us to have that. As I expanded to what you were talking about, which is the other 2 hospitals in Palmer and Westfield, that definitely was no longer the case in terms of access to treatment. So what you're talking about in Westfield was we started seeing patients maybe 2 months ago there, and you'd say, okay, let's start you on buprenorphine or whatever we're going to do. Excellent. Okay, who's the local buprenorphine provider? There's not one. We called around, me and our really great recovery support navigator, called every single provider. We looked up lists of people with DEA numbers, right? Every single provider in Westfield. And I offered, I'll come down, I'll help you, I'll talk you through it. It's really not that hard. I'm doing the hard part in the hospital. All you got to do is, you know, keep writing the script. We got no bites. Not one single office, not one single psychiatrist, every single person we could think of to call, none. Which is, it does shock you a little bit, right? So the state of what it was there. And so you know, you can get around that to some extent because you can do telemedicine. So I've been seeing patients essentially that are, we start them wherever they are, and then if they can't get access, I do telemedicine only from there on out. How long that situation will last that I'll be able to do that, I don't know, but that's okay. The other big access point in terms of treatment was if they need an injectable, of course, there's nobody that they can go to in Westfield, and that we have somewhat worked on, and we're, I would say any of you, if you're working in hospitals, a kind of really nice resource, if you aren't doing it already, is talk to your infusion suite managers, because this is something that they can do. It's easy. All you have to do is get it REM certified. Literally, that's it. And get buy-in, of course, from the providers there. But if you can do any of the Vivitrol, Sublocade, Brixadi, any of these can happen right in an inpatient setting, just at the infusion suites. These are considered outpatient. We cleared this all. The insurance will bill for it. We actually have not given an injection yet, so I guess maybe I should hold that. But that has been certainly a big help for us for a lot of people, that even if you are, it's a little bit more complicated, but even if you're doing fully telemedicine, you can send the script through a specialty pharmacy to the infusion suite, and that seems to be something that is going to work out. So I'm rambling a little bit, but I think that's what you were looking for.
No, that's perfect.
Thanks.
That's awesome. Yeah, I mean, you're being creative, thinking outside the box, and how to make sure people are getting access to what they need, in this case, medications. So when I was talking to Allie about just what's happening in her hospital, we talked a lot about recovery coaches and how they're part of the team. So can you just tell a little bit about how recovery coaches are part of the team, and then anything in terms of how they've impacted care and transitions?
Yeah, absolutely. Thank you. I wasn't able to be here yesterday, so I missed the mic tutorial. So I hope this is okay.
Yes.
We brought a recovery coach onto our team just about 2 years ago now. The original idea behind it was really to help transport patients to their methadone clinics following hospitalization. We were finding that we were starting patients on methadone while they were in the hospital, setting up direct admissions for them to be able to continue dosing when they leave. And then it came time to discharge, and patients weren't able to get there. And yes, you can get a ride through your insurance, but you have to be able to get to the clinic first before that can happen. And so we brought my buddy Chris on to be able to pick patients up and actually drive them himself to the clinic until that ride can go through the insurance, which logistically has been great. Patients really sort of were falling out of care before they even had a chance to get stabilized, and he was bridging that gap. But I think beyond logistics of it, it has just been a huge support for patients. I think we've all heard patients' experiences going to methadone clinics. You know, I went once, it was horrifying, I never went back. And really to have someone there with you, supporting you, coaching you through it, kind of preparing you for what that line might be like, and really to walk beside you through it has been huge, really, for patients. I think one of my favorite stories through this was a 19-year-old patient. We'd been working with him outpatient for a few months, trying to get him stabilized on bupe, and he just kind of couldn't stabilize quite enough. He ended up presenting to the hospital with an overdose and said, you know what, I think what I really need is methadone. He was pretty naive as far as treatment goes, had never been to a methadone clinic before, had never been to an inpatient detox. And Chris jumped in and drove him at least for the first week, and they still work together now. It went much better than I think it ever could have had Chris not been there to help support him. A few months into his treatment, actually, Chris and I were sort of, making a plan for the day, and he said, I won't be available around whatever time because, this patient actually just got a new car. He's really excited, so I'm gonna go take him out for coffee to celebrate that. So that was a really great outcome. His role has really expanded much beyond just transporting patients to the methadone clinic. I think oftentimes when we see patients in the hospital, they're really at their lowest of low, and maybe they're so far from where they would like to be that they kind of can't really envision anymore ever getting there. So to have a living, breathing, live in color example in front of them saying, I've been where you are, here's what worked, it was a lot of work, but this is what I did. It really instills hope much more than oftentimes I can say, here's the science, here's the medicine, but it's much more meaningful to have somebody there who has lived through it and is doing it. It's been a lot of fun to see how much Chris has learned and grown throughout the process too. Sometimes we'll be doing a consult and I'm like, hey, that's my line. What are you? But it's been really great. And yeah, I can't say enough about how valuable it's been.
That's great. Chris here? Oh, okay. Shout out to Chris. All right, so now we're gonna transition to the emergency department, which really for us is the front door of our house. That's where everyone comes in and where we meet a lot of our folks. So in Holyoke, we had, I think this is out of order because I'll go back to you, promise. In Holyoke, we had a bit of a summer and it was challenging. In August, we had, at least from what I could count, 79 non-fatal overdoses. 52% of those individuals were Hispanic and 43% were unhoused. It was rough. I had messages from Mel saying, what are we doing? What's happening? So can you just talk a little bit about what those looked like, how we collaborated, and just how we kept your team up to speed with what was happening? Not really.
How about that?
Yes.
Yeah. So we knew this was coming because you, as usual, sent me some email about something coming down the pipeline, and I think it was in Philly and New York. And so we had about a 2-week heads up about what was going on with, in our area, it was called Superman or Get Lucky, or somewhere Nipsey Hussle. So I had kind of sort of watered down what we needed to know because emergency medicine doctors want a little bit, want it fast, and they just want to know what they need to know. And so we told them that carfentanil is coming and medetomidine, also known as Dex in the community. And so we kind of relate it as, think about this patient being on Precedex strip, which they're all comfortable with. So you're going to see hypotension, you're going to see bradycardia. But the studies in Philly, even though it was limited, I think it was around 100 patients, showed a lot of these patients needed ICU level of care. Some patients were on pressors. They were out for 15 hours. And that's exactly what we saw. So our emergency department was filled with overdose patients who were either on Levophed, some ended up getting intubated, people went to tele. And so this very short email that I had devised from Maria's education went to our hospitalists, went to our intensivists, went to all the EMS departments because I'm the director. Our nurses got it. Everyone wanted to know. Our patients knew. It was on Facebook groups. The only thing I would say that was very frustrating from the process, Maria and I were talking too much. We were talking to Tapestry, all these people, but there was nothing put out there to really warn the community. And it felt like it was us to do it. There was nothing on the news. There was things in Holyoke face groups. And about, I'd say 4 or 5 days in, the police showed up and started to tell us, hey, this is happening. And I said, we're already living this. So thank you. And, I mentioned Maria had already warned us, so my team already knew. So I think our team handled it really well because we were prepared. And the only reason we were prepared is because we have such a good relationship with the addiction medicine team. And we have a very different culture at Holyoke for providers. And it was not easy to build, but we aren't perfect, but we are getting there. And so we handled it, I thought, very well. It was scary, but we were way ahead of everyone. We got it out into the news. It was pretty much that email they were sort of copying. It showed up on social media. So we did great. And as far as we know, they were almost all, we were able to recover, almost all.
Absolutely. Yeah. Yeah, that sucked pretty much. It was just really challenging. Staying in the ED, like I'd said before, the South Shore ED is massive. And I was really curious about how they handle just that volume and being able to see patients and screening. So tell us a little bit about how that the expert role?
Yeah, so in addition to our addiction medicine consult service, we also have clinicians that work out of the emergency department. Every patient that comes through our emergency department gets a few questions about their drug and alcohol use. And anyone who answers yes to any of those questions, it triggers an expert consult. These clinicians meet with the patient, they sort of gain a history, gauge where the patient is at, maybe try to figure out what they're looking for, if anything. And I've really come to think of this service as almost addiction treatment triage. So they figure out what the patient's looking for and they help make it happen. If that means the patient wants a detox bed, they will start a bed search and help get that going. If they really are needing outpatient services, they will, once the patient is medically cleared, they'll sometimes walk the patient across the street to our outpatient office. One example recently, the patient was wheeled across the street, which if you know the route, you might say that was dodgy, and it was, but it went okay. And, or if there's something more needed medically while they're there from an addiction perspective, they're able to place a consult for us to see them. They are there much more expanded hours than our consult services. So it really just helps us cast a wider net to reach more patients so that we never want a patient to leave the hospital who really could have benefited from some type of service that left without knowing where to go. And I think that probably happens more than, I would care to admit, but this definitely helps prevent that. And it will actually be expanded soon up to all patients on the floors as well that maybe got missed while they were in the emergency room. So always working to do more.
Oh, that's great. I didn't know that. So a little bit about discharge instructions. So stigma, obviously, we know is something we continue to see and address. But for me, I see it constantly when I do chart reviews, just in the way that notes are written. And I always had a really hard time when it was like the discharge instructions from the emergency department saying, go to detox or stop using drugs, or, drugs can kill you. And I really wanted to figure out a way to change that. So I actually worked with Mel around this. And this is a snippet, like you definitely can't read it, I think, from there, but it's, much less stigmatizing, really using clinically appropriate terminology. It talks about, number one risk for fatal overdose is using alone. So we include information on Safe Spot. We include information on Tapestry Health, which is our local harm reduction partner agency, and also including things like you can text them and they will bring you supplies if you need them. And then information about our outpatient MAT office. How did that go? I never even asked you. How did that go when you brought this up for the ED providers? Because we made it just put it in the EMR. So when somebody comes in for overdose, and I don't know if it's like problem or something, and then you click discharge instructions, it's automatically already created. So how did it go in terms of sharing that with your team, and then overall just continuing to strengthen the culture?
I mean, easy, because our culture's already sort of been built and everybody likes canned text, right? It saves you time. So this was easy. Do you want me to talk about more about how, like, the culture, what we did?
Sure,
or?
go ahead.
So I was there a little bit before Maria, and just working as like a shift clinician. Definitely walked into a group that had a lot of prejudice toward our most at-risk community. And so slowly infiltrated them. It was, myself, Maria, our APPs, who really, I think our APP shined. They were young, diverse, new, and, when you started using words like standard and excellence of care, and I definitely embellished and said that we were behind everybody else, which was not true, but they didn't know that. We just started prescribing in the ED. Just like if a patient needs insulin, they need methadone, great, you're gonna get methadone. Kind of got away from the, oh, you're here again, oh, like it's an overdose, they're never gonna stop. It was more, we changed the like, hey, are you okay? How can we help you? Getting recovery coaches involved, getting Maria involved early, particularly for the admitted patients. Admitted patients, they were started on, you know, Toradol, IV Dilaudid, methadone. And then the next day you'd get a call from the hospitalist being like, you started this patient on methadone. And I'm like, yeah, continue it. Like, and so that definitely changed where we were at in the culture. Not everyone bought in. And of course, those people are always slowly weeded out and, you know, they weed themselves out. But I think we're known in the area now for, if you need help, we are going to help you. We'll do the best we can. We're not perfect, but our job is, you know, my job is to save lives, right? And so it might not happen that day, but it might be that we were kind enough and showed them enough respect, you know, that we were just being humans to humans. And then they show up in the clinic and they say, hey, they were really kind and I sort of changed my mind. Can you help me? And so those are the things that we're really trying to do. We're not expecting the Hallmark Channel every visit. But, you know, when I first started, there were so many infections, there were so many endocarditis, there was people with emboli to the brain. And now that's sort of a little bit rare. You see one maybe once every few months, but this was like every shift you were seeing numbers. And I think Maria had a master plan and, you know, really we followed her lead of what needed to be done. But I'm very proud of our group. And this was easy. I mean, this wasn't no problem pulling it out. And my office is in the ED. So if you put in stop using drugs, I will track you down.
Audra. Audra is doing some pretty cool things at her hospital. And what is that smoke? Do you smell that?
So smoky, right?
Smoke. Oh, okay. Okay. We don't have to evacuate. Okay. So tell us a little bit about how, what you're doing in the ED, how this was born in.
Can you hear me?
Yeah.
Yeah, thanks. So we are lucky enough, I think just to preface how this came about, is our consult service grew out of the Bridge Clinic first. And I think that's really actually been extremely helpful. The Bridge Clinic existed first as an acute stabilization, first as like mental health support for crisis stabilization. And then through Mass Heal, got more support to be an addiction Bridge Clinic. And then funded the first nurse practitioner to be doing some consults. So it grew as sort of this partnership. So we all work in both settings. And so I think that gives us a really cool perspective and also direct access to follow-up care. So that makes a lot of things a lot simpler for us. We also have recovery coaches that work out of the Bridge Clinic and interface every day with the ED for people who want higher levels of care. And also see patients on the inpatient service. Staffing has been limiting. So getting everybody seen by a recovery coach has been really hard, but that is definitely a goal. So anyway, that being said, we had in the Bridge Clinic been doing some low dose bupe inductions, like I'm sure many of you guys have, and realizing that the overlapping agonist has been helpful to smooth out that low dose induction initiation. We have been using a pretty fast protocol of 3 days, and I think that it's been really, really successful in getting people on a full dose sort of at the 48-hour mark by the 3rd day, but really knowing that with that, the full dose is helpful. And so in the Bridge Clinic, we were often encouraging people or just at least acknowledging that people might need to continue some amount of full agonist, whether that was their own substance. And it was really hard to recommend that, especially as people were finding that that is extremely triggering and hard as they're trying to get off the substance. So we, in the inpatient side, had control over a protocol, so then made the protocol have overlapping methadone. And then coming to conferences, talking to everybody, different people in this room about the 72-hour rule, we sort of realized that there was no reason that we couldn't try to do an overlap with methadone and the low dose kit. And so that has been our newest project. And since this spring, we have these kits being handed out actually by our emergency room teams to anybody who wants to get started on bupe. So we had initially, our primary goal, I think, it's all of these goals at the same time, but we had initially thought we wanted this for the Bridge Clinic because we were already telling people, go ahead and, you know, we encourage you to use an agonist, but we didn't have access to it. There's more barriers there because we can't or schedule medications. We don't have our own DEA license. So this has been our sort of interim plan, but it's really great because now it's built for anybody who does present to the ED. Because they're in the ED, they get the first dose of methadone, the first dose of a 0.5 bupe. And I think that's actually really helpful because people can be convinced, like, I won't feel terrible. So I don't think it needs to be the rule that people have to stay for those first doses, but in the right situation, I think it's reassuring for people to know, like, you're going to go home and be able to continue this and feel okay. And it goes just in a little baggie from the pharmacy team. It's stored in the Pyxis or Omnicell, I'm not sure which brand, but it can go right to the patient with Narcan. And then we have the ability to see them within the next couple of days to continue bupe. And we're hoping to explore even using the long-acting injectables sooner in this protocol as we get them more available for inpatient or ED use. So we're working with BSAS and support in making that happen.
That's really cool. Very exciting. Don't you think, Mel?
I know.
Yeah. Okay, so just transitioning over to collaboration with community agencies. I was going to include really our work with collaborating with our community providers, OTPs, and OBATs, but I really just don't think that's innovative. I really think that should just be standard of care. I think it's really important if we're working in an addiction consult service that we work closely with our community providers, whether patients are currently engaged in care, if we're getting them started in care, we should have a good working relationship with our community providers and be able to do direct admits. But of note, some of us are still having challenges with doing direct admissions for OTPs. I'm just going to go through this slide quickly just because, just in a matter of time, but when those overdoses were happening, Mel had mentioned, we called Tapestry Health and they do community drug checking. So if you work with a local harm reduction agency, find out if they do drug checking. And these are really, really, really helpful reports because from them, we also got the confirmation that, yes, this is what we're seeing. These are the stamps on the bags. And then this is how patients are, or participants as they refer to them, this is how they're presenting. And it was really helpful. We had a call with them when this was all happening with the overdoses. Audra, in talking with Audra, she was telling me about a really great collaboration that she was having with 5 minutes with a community provider around treatment for alcohol use disorder.
We have a ton of consults for alcohol use disorder. And I think that it seems like that's pretty consistent for a lot of consult services. It's definitely over half. So we're spending a lot of time talking about alcohol, talking about recovery from alcohol, and using a lot of Vivitrol. We are seeing a lot of people with end-stage liver disease or, at least fibrosis cirrhosis on a regular basis. And one thing that we see all the time is that GI tends to say, recommend, encourage, urge abstinence from alcohol, follow up outpatient. And then we know that our patients are not getting access to GI. What has been really incredible is there's a new doctor at Tufts downtown and Tufts Medicine, and we're, as Lowell General, we're now part of Tufts Medicine. She's a transplant hepatologist and is really, really proactive about getting people engaged in care with alcohol use disorder, and has changed the guidelines to be able to offer transplant sooner without a restriction on the timing of sobriety. So they have the most liberal process in the Boston area, at least, if not further in the region. So if anybody needs access to care, feel free to reach out to them. But she has worked with us a little bit in supporting our use of Vivitrol in patients with decompensated cirrhosis and sort of eliminating the concerns that we have previously had about the risk for risk with liver disease. It's not well studied, so that's something that we're really excited to get more information about, or help support that in any way we can. But without data, and with some more recent data saying that it's safe, we're giving a lot of Vivitrol in decompensated cirrhosis and beyond. And through this partnership, we sort of have realized that none of our patients are getting access to GI. None of our patients in the hospital are, even with a MELD of like, 25, 30, are getting even referred to the transplant service. And she has been trying to reach out to local GI offices without a lot of luck. And we are in the process of coordinating the possibility that she could come work out of our bridge clinic one day a month. So that is really exciting. And I think one thing that our patients really have not had access to in any way. And we had a patient, Joyce, one of our NPs is in the crowd, and our team has had a patient who has had a successful transplant through their service. This is now like a year or so ago, but it wouldn't have been possible, I think, without them being a little bit more liberal and being able to partner with our team. So it's been great. Yeah, Allison Kaplan. And her colleagues, I should say too, seem to be equally supportive of the new protocols and working with patients with substance use disorder. Very impressed. Yeah.
So this is the last slide. This is literally the last slide. So that was, like I said, there's a lot that we could continue to talk about. I think just common pain points that came up for us, and I heard them yesterday, were continue to have challenges transferring people to skilled nursing facilities. There's 0 in Western Mass. So all of my patients that need to go to a skilled nursing facility have to go an hour plus away. So imagine being an hour plus away with family who doesn't have transportation, any ability to continue to see you. I don't blame them either for not going, because I wouldn't want to sit somewhere for 6 weeks. And then addressing substance use in the hospital and just many, many more topics, but that was it. Thank you so much to all of you for sharing what you're doing, and thanks to all of you for listening. Okay.
Now, right? Oh, okay, one question. Hi, Megan Miller, OB and addiction medicine at BC Medical Center. So since it's there and it's something that I've really wanted to address in our hospital, especially in the obstetric side, are any of you doing any work in the addressing substance use in the hospital? Are there any guidelines that are available? Because I hate to reinvent the wheel.
Quickly, just that we don't have a lot of guidance, I think, around this at all. Our old policy actually on the OB floor was to do room searches, including of visitors. And so that was something that we were able to get rid of and get people on board with. So I think that as like basic of humanity changes needed there, I think surprisingly was still met with a little bit of resistance and had to work through that. But I think at the bare minimum, I think that's a place to go. Yeah.
Yeah, people, I don't know. Is this on? Okay. I don't think we have a very specific policy around use. We definitely have some policies around things being found, maybe searches, and those have changed. I know that Boston Medical Center recently shared their policy that they had completed with us. So I'd be happy to share that with you around that. But that's a great question. Continues to happen. Our next speaker starts at 10:15. We have a couple. You have a question?
Hi, Talia, BMC and BHN. So I work in 2 separate places in Massachusetts, Springfield, Holyoke area, and Boston. And I tend to see a lot like things sort of like the metatomidine starting in one place and then taking a little time and then drifting one direction or the other. So I'm wondering if there's any system for like when you're seeing something at Holyoke Health Center or Holyoke Hospital, any system to sort of warn ERs in other places in the state, this might be coming your way. This is what we've learned. And specifically for me, can I have you talk to BMC ER? Because I know that's probably coming our way as well.